In this video, I'm going to teach you everything you need to know to manage cirrhosis. Because there are so many complications with cirrhosis, it can be very helpful to have a mnemonic to remind you, sort of like a checklist of the things you need to look out for in these patients. So there's this mnemonic called VIBES, which is becoming more popular recently, and it stands for volume, basically talking about ascites, infection, aka spontaneous bacterial peritonitis, bleeding, such as from varices, encephalopathy, and screening. So these are basically the most common things that you are going to have to address in most of your patients with cirrhosis being admitted to the hospital. Our mainstay of therapy for ascites is going to be diuretics, and what you really need to know is that we typically use a ratio of spironolactone to Lasix in a 5-to-2 ratio. So for example, somebody may be on 100 milligrams of spironolactone and 40 milligrams of Lasix, or 50 milligrams of spironolactone and 20 milligrams of Lasix. Spironolactone is actually the main driver of diuresis in patients with cirrhosis. However, it can lead to hyperkalemia, so the Lasix kind of balances that out by allowing them to excrete potassium. The other option that we have is paracentesis, and we do this both for diagnostic purposes and as well as therapeutic purposes. So a diagnostic para would be basically just taking off 50 cc's just to send some tests, check for cell count and any bacteria that's growing there, versus a therapeutic or a large volume paracentesis, which is when we are removing ascites for symptom management. For example, if they're having shortness of breath or painful distension, then we can remove multiple liters of fluid from their abdomen. One thing that is actually very commonly missed is that all patients who are admitted to the hospital with ascites, regardless of whether they have abdominal pain or fever or signs of infection, should undergo at least a diagnostic paracentesis. The reason for this is that we are actually very bad at clinically judging if a patient is having SBP or not. And a lot of these patients may not give the classic clues or signs of infection. For example, cirrhosis patients tend to be hypothermic at baseline, and so they may not spike a true fever when they are admitted to the hospital. And they don't always present with abdominal pain. So any patient with ascites that's admitted to the hospital, even if it's for some unrelated reason, should undergo a diagnostic paracentesis. Next, when we do a large volume paracentesis, we typically give some albumin in order to prevent third spacing of fluids back into the peritoneal cavity where you just removed ascites from. So typically what you'll see is they'll recommend 6 to 8 grams per liter of fluid removed after about 4 to 5 liters. So typically at our institution, we do 25 grams of 25% albumin every 4 liters removed. And that kind of hits that 6 to 8 grams per liter recommendation that's out there. And a key point here is that we want to use 25% albumin rather than 5% albumin. Those are mainly your two choices. And 5% albumin is, just as you expect, less concentrated than the 25% albumin. And so you're just giving more volume back by giving 5% albumin. And so you always want to be giving that 25% albumin. One of the things that we look at when we send a diagnostic paracentesis is something called the serum ascites albumin gradient. And this is especially important for patients who are coming in with ascites for the very first time and you aren't 100% certain on the etiology yet. So there's two big buckets. We have a SAG of greater than 1.1 and a SAG of less than 1.1. And the patients who are here in this greater than 1.1 are described as having portal hypertensive etiology to their ascites, whereas the less than 1.1 is non-portal hypertensive. Just an example of how we calculate the SAG. So let's say that your serum albumin is 2.5, and then you have an ascites albumin of 1.0. Basically, all you have to do is subtract 1 from 2.5, and you get 1.5, which is giving you a SAG of greater than 1.1. So this patient would fall into the portal hypertensive etiology of ascites. Now, if you had a higher amount of albumin in the ascites, for example, if it came back at 2, now all of a sudden your SAG is 0.5 and you would be falling into the non-portal hypertensive etiology. The other branch point that we check here is their total protein of less than 2.5 or total protein of greater than 2.5. And typically when you see a lower total protein, that's going to be more consistent with cirrhosis, and a higher total protein is going to be consistent with cardiac ascites. And the way you can think about that is the liver is involved in the production of many proteins in our body. And so in cirrhotic patients, they just lack all of those proteins. And so you don't actually see any of, a very high amount of protein in their ascites. Whereas with cardiac patients with severe heart failure, for example, they still are producing a normal amount of protein. It's just that they have that high hydrostatic pressure that's pushing fluid out into their peritoneal space. In regards to the non-portal hypertensive etiologies, these are again states in which you have a lot of albumin in the ascites fluid. And so you're going to see this in things like peritoneal carcinomatosis, so malignancy, TB, and nephrotic syndrome. Another thing that we are not very good at is that in patients with ascites, especially if their blood pressure is starting to drop, it is actually recommended by the AASLD that you should consider stopping beta blocker prophylaxis if they are on it, especially propranolol, because it's shown actually decreased survival if you're on propranolol, as well as ACEs and ARBs. Finally, if you have refractory ascites, then one thing that you can consider is a TIPS, which is also known as a transjugular intrahepatic portosystemic shunt. So basically how it works is you have your scarred, fibrotic, and very stiff liver. And what happens is flow through the portal vein gets obstructed. And so basically it starts backing up. And this causes the portal hypertension that leads to ascites and everything like that. And then meanwhile, you have your hepatic vein over here and your IVC like this. And so what they do is they're going to do a shunt to just bypass the liver. And so what they do is they just kind of go in and directly connect the IVC to the hepatic vein, and that allows the fluid to just bypass the liver, thereby improving the portal hypertension and your ascites. But there is one significant risk with doing a TIPS procedure that you should know about, and that would be increased risk of encephalopathy. All right, so moving on to infection next, the main thing that we are concerned about here is SBP, or spontaneous bacterial peritonitis, which is when that ascites fluid gets infected by bacteria, and this can be a quite serious infection. And the way that you do it is via your paracentesis and looking for PMNs or neutrophils greater than 250. If you meet that threshold, then you are automatically already diagnostic for SBP. You don't need positive cultures or anything like that. Typically, our treatment is going to be ceftriaxone for 5 to 7 days, as well as albumin. And the way that we give this is pretty interesting. So we give 1.5 grams per kilogram per day on day 1, and then we give 1 gram per kilogram per day on day 3. The reason that we do this is because of the albumin for SBP trial, which showed decreased risk of hepatorenal syndrome when patients were given basically prophylactic albumin if they had SBP. The next thing to address in these patients is prophylaxis. So basically, any patient who has ever had an episode of SBP before needs to be on lifelong prophylaxis. So lifelong after any episode of SBP. And this is typically going to be with trimethoprim, sulfamethoxazole, or ciprofloxacin. So that would be secondary prophylaxis. We also have indications for primary prophylaxis for patients with very low total protein in their ascites fluid and with any degree of renal and hepatic impairment. And so the indications for this would be ascites protein less than 1.5 with basically any of the following. So creatinine of greater than 1.2, BUN greater than 25, sodium less than 130, a child Pew score of greater than 9, or a T-Billy of greater than 3. All right, so that would be primary prophylaxis. And then there is one final recommendation that if there is somebody who is hospitalized with ascites protein less than 1.0, then they recommend treating them prophylactically while they are in the hospital, and then they can discontinue it once they're out of the hospital. Another medication that's very important to stop after any episode of SBP is stopping any PPIs, because these are well known to increase the risk of SBP, basically by reducing the amount of acid in the stomach, which allows more bacteria to grow and to potentially translocate. So anybody who's had an episode of SBP should have their PPI discontinued, which is something we miss very often. Next, we're going to move on to bleeding, and I like to separate this into what we're going to do acutely and what we're going to do chronically. So acutely, they are having a rupture of an esophageal varice, which again is a complication of having increased portal pressures, which is leading to dilation of those esophageal varices. And this is a very high mortality, high risk of mortality event, up to 30% mortality, and a third of patients will have survival of less than 1 year. So in this case, what we do is we do a PPI. Typically, we give them a loading dose and then we do IV BID. There's been no benefit that's been seen with a PPI drip, although you will see some people using this, thinking that a PPI drip may be more efficacious up front. Then we also give ceftriaxone, which is for SBP prophylaxis. And we also give octreotide, which is a splanchnic vasoconstrictor, basically trying to reduce the portal pressures that's leading to the dilated varices. You're also going to need a GI consult because these patients are going to need endoscopy for control of the bleeding, possible ligation, and 2 large bore IVs, typical, what we would see on our exam questions. You're always going to need that 2 large bore IVs. There is something interesting that I want you to know about, which is called a Blakemore tube. And this is something that GI can put in if there's like severe bleeding that's going on. It's basically a balloon that's going to expand in the esophagus and basically tamponade off that esophageal varices that's bleeding. So if needed, for example, a patient that needs airway protection or is having very severe bleeding, consider intubation or Blakemore tube. On the chronic side of things, it's all about beta blockers, which is basically going to reduce the risk of the varices from rupturing. And so one thing that's very important is do not start beta blockers in the acute GI bleed situation. This is going to be something that's more for the chronic management. And so our options here are propranolol, nadolol, and carvedilol. Typically, they recommend propranolol or nadolol if it's decompensated cirrhosis, and carvedilol is a good option if compensated, with a goal heart rate of 55 to 60. But again, remember, if they're having worsening blood pressures, if they have significant ascites, then you should really consider stopping this beta blocker prophylaxis. If unable to tolerate beta blocker prophylaxis, then they should basically see GI for possible ligation of their varices. All right, next we're going to talk about encephalopathy, which may be one of the most common complications that you're going to run into in patients with cirrhosis. This occurs in up to 45% of patients with cirrhosis and is actually the most common decompensating events in patients with MASH cirrhosis. So our go-to treatment is lactulose with a goal of 2 to 3 bowel movements per day. If it is recurrent or refractory, then we add on rifaximin. There is also some evidence for zinc sulfate. One of the things that we have to do is rule out any precipitating factors. So the most common precipitating factor is non-adherence to lactulose, but it becomes very easy for people to just anchor on that and not fully rule out other causes of their hepatic encephalopathy. So it's very important to rule out infection, overdiuresis, or dehydration. Hypokalemia is actually a really big one because when you have this going on, you actually have increased ammonia production in your kidneys. A GI bleed is also another potential precipitant of hepatic encephalopathy. One of the things that I like to teach on physical exam is that not all patients are able to do asterixis for you, especially if they're altered. So another alternative is checking for milkmaid's grip if they cannot do asterixis. And so this is basically you just asking them to squeeze your fingers. And then if you see this kind of rhythmic loss of tone, that kind of occurs due to the same mechanism of asterixis, which is this negative myoclonus. And this can be really helpful in those patients who are unable to follow commands properly. And then finally, one of the things I like to teach a lot about lactulose is its mechanism of action, because I actually feel like it has one of the most interesting mechanisms of action out there. So basically, if I draw the colon right here, basically, you're going to have the colon like this. And what happens is lactulose, it's a sugar that we are unable to digest. And so what happens actually is the bacteria start to digest it instead. And what they do is they release a lot of H+ ion into the colon. And so this essentially acidifies the colon. And what happens is you have a lot of this ammonia that's kind of running around, and it ends up binding this H+ ion to form ammonium, which is not reabsorbable by the body, whereas the ammonia is. And so now that you've made this non-absorbable form, it's all going to get excreted through the bowel movements. And so that's why making people poop a lot on lactulose actually helps hepatic encephalopathy. All right, the next important thing is to talk about screening. And so these patients are at high risk for cancer. They're at high risk for esophageal varices. And so getting these patients set up for discharge, you're also going to want to make sure that certain things are in place. So usually what we do is a Q6-month right upper quadrant ultrasound for hepatocellular carcinoma screening. We do an EGD every 3 years to check for esophageal varices, and if they start to develop, then they have more frequent surveillance. We want to make sure they have hepatitis A and B vaccinations just to prevent any further insult to the liver. And then another important thing to note is that if their MELD score is starting to go above 10, they should be referred for liver transplant evaluation, basically because this is the point where they're going to be able to start getting on the list, and it's a very long process to get a liver transplant. They have to go through all the socioeconomic factors, psychosocial factors, basically just to make sure everything is as optimal as possible, and this can be like a multi-year process. So once the MELD is starting to get higher, they should have a referral to a hepatology liver transplant center. All right, so now I'm going to go over some additional complications of cirrhosis that don't necessarily fit in the vibes mnemonic. The vibes mnemonic is going to have the most common ones that you're going to encounter basically day to day, but these other complications are also pretty common, and so you will definitely encounter them as well, so you'll need to know about them. And the first one we're going to talk about is hepatorenal syndrome, and this should be something you always consider in a patient with cirrhosis with an AKI and ascites. Ascites is pretty much a prerequisite to having hepatorenal syndrome. And also, they typically have a low blood pressure as well. And so the reason this happens is a very interesting as well mechanism. And so basically, again, you have your scarred down liver. You're getting portal hypertension. You remember we had the hepatic vein that's really dilated. And basically, in your gut, you have this splanchnic circulation. So what happens is you have all this backflow of venous blood into your splanchnic circulation, and you also have the release of nitric oxide, which further causes splanchnic vasodilation. So now you're just getting all this blood that's just pooling in this splanchnic circulation. And so if it's in this circulation, where is it not? Well, it's not in your arterial system, which is going to your kidneys, right? And so now you've got your kidneys over here, and what's going on with them is there's barely any circulation that's going on systemically in the arterial system. And so now they are starting to get an AKI. They're basically feeling hypoperfused. And so that's why you start to get an AKI. Essentially, it's a form of decreased effective circulating volume. You may hear that term thrown around a lot. All right, so what do we actually do about this? Well, the first thing that we do is something called an albumin challenge, where we give 1 gram per kilogram per day times 2 days. There are some studies showing that 1 day may be sufficient or not, but basically we want to do this albumin challenge up front to determine if this patient is just having a pre-renal AKI or if they are truly having hepatorenal syndrome. So if they respond, then basically they had a pre-renal AKI. If they don't respond, then it's likely hepatorenal syndrome. I also want you to know that hepatorenal syndrome is characterized by an extremely low urine sodium. And the reason I want you to know this is because things that are intrinsic, like glomerulonephritis or ATN, those are all going to have high urine sodium. And so another clue for hepatorenal syndrome is when you have a very, very low urine sodium, and this is often tested on board exams. So in terms of treatment, we should immediately discontinue beta blockers and diuretics. And then we are now favoring terlipressin plus albumin. In the past, we were using octreotide plus midodrine plus albumin. And then also in the ICU, we use norepinephrine plus albumin. So basically, this is on the floor, this is in the ICU, and this is if terlipressin not available. And so basically what we're trying to do with all of these, they're basically all going to be causing vasoconstriction in the splanchnic vasculature in an attempt to push more blood back into the systemic circulation to help perfuse those kidneys again. And then albumin, again, is just to try and kind of reduce all that third spacing that patients are having and pull everything back into the vasculature. If anybody is at risk of hepatorenal syndrome or they have any signs of kidney dysfunction, just as a general prophylaxis rule as well, these patients should have their ACE and ARB discontinued as well. And so you can see there's clearly many situations in which we stop beta blockers, we stop ACEs and ARBs, we stop PPIs if they're having SBP. And a lot of this is due to data that shows that when cirrhotic patients have a MAP of less than 82, their 1-year survival is like 20%, and their 2-year survival is 0%. It's extremely high mortality once their MAP drops below 82. So whenever you see any antihypertensives, beta blockers on a cirrhotic patient with low blood pressure, you immediately want to stop all of these medications because you're increasing the risk for all-cause mortality, you're increasing the risk for hepatorenal syndrome, and all these other complications as well. The next complication I want to talk about is something called hepatopulmonary syndrome, which is a pretty interesting situation. And so this one actually is just interesting in the exam or how it presents. So these patients will have something called orthodeoxia plus platypnea. So basically, you know how CHF patients have shortness of breath when they lie flat because all of a sudden all that fluid is just kind of backing up, filling up their lungs and causing shortness of breath. Well, in hepatopulmonary syndrome, actually these patients feel more short of breath when they're sitting up and it's relieved when they're lying down. So shortness of breath and hypoxia when sitting upright, which is relieved with lying down. So this is a very interesting kind of exam or history finding. And so the reason that this happens is that when you have really bad cirrhosis, you can get these intravascular, intrapulmonary dilations that can form at the base of the lungs. So if I draw the lungs out for you guys here, you'll see that, let's say at the very base, you've got all these vascular dilations that's basically causing shunt. And basically, it's not getting any gas exchange. It's just going straight from the right side of the heart to the left side of heart without being oxygenated at all. And so when you're sitting upright, gravity is pulling blood down, right? So you've got your arteries, your pulmonary arteries coming in here. And maybe I should draw them blue since they're deoxygenated. And then your pulmonary artery coming in here. And all of this blood is being distributed to where all these vascular malformations are. And basically, when you lie down, you're actually now redistributing some of that blood flow to go somewhere else, which is up here in the apexes where we don't have as many of those dilations. And so this is why patients with hepatopulmonary syndrome actually feel more short of breath when they're sitting upright, and they feel relieved when they're lying down. Something that can increase your suspicion for hepatopulmonary syndrome besides the history is increased number of spider, nevi, and angiomata, which basically, again, are all kind of like these vascular malformations. So if you're having a lot of those on the skin, you're just at higher risk for having a lot of those going in the lungs as well. Echo with contrast / bubble can help you check for any intrapulmonary shunt. So typically you will see bubbles appearing in the left side of the heart 3 to 8 cardiac cycles after it's instilled. Whereas if somebody had an intracardiac shunt, it's like 1 to 2 cycles. It's immediately seen in the left side of the heart. Unfortunately, it's very difficult to treat. And ultimately, these patients will need a liver transplantation for definitive treatment. Otherwise, they get put on supportive treatments like oxygen and things like that. But really, the prognosis is not very good. And perioperative mortality with liver transplant is also very high in these patients. We also have something called portopulmonary syndrome, which I want you to be aware about. And this is another thing that can cause shortness of breath in these patients. And it's basically a form of WHO group 1 pulmonary hypertension. So it's basically pulmonary hypertension in the setting of liver disease. It's essentially like categorized as WHO group 1, which means it does respond to those treatments that are there for WHO group 1, which is like those endothelin receptor antagonists and phosphodiesterase inhibitors. Previously, it was a contraindication to liver transplantation. However, now some select patients may qualify. And so the reason it was basically an absolute contraindication in the past is because if somebody has very severe pulmonary hypertension, and sorry, this is not portopulmonary syndrome, but portopulmonary hypertension. But if somebody has very severe hypertension in their pulmonary vasculature and you transplant a new liver, basically all the fluid is just going to back up into the liver again, cause congestion, congestive hepatopathy, and basically kill off the transplanted liver again before it really got a chance to establish. So that's why these patients, it has to be very selective about which ones can qualify for a liver transplant. Hyponatremia is extremely common in these patients, and it's because these patients have increased release of ADH. Again, this is because in their systemic vasculature, the kidneys feel hypoperfused, and so they're trying to retain more fluid. The reason that I add this here is because up until fairly recently, actually, I didn't know that in this case, we use 25% albumin to increase sodium, not normal saline. So this is something important for you to know. Hepatic hydrothorax is another complication that you may see. And essentially, it's going to be when you have somebody with a pleural effusion on the right side that's like right above their liver. So let's say you've got your lungs here, you've got your diaphragm in the middle, and then you've got your scarred liver underneath. What can actually happen is you basically get ascites that is around the liver, and it starts to, instead of going into the peritoneal cavity, sometimes it could just go up into this area right here and cause a big pleural effusion just right above the diaphragm over that right lung. So that's something that we can sometimes see. And these pleural effusions, we generally don't want to place a chest tube or anything because it's just going to continuously drain out and drain all of the patient's electrolytes and proteins and other things like that. And so no indication for chest tubes to treat hepatic hydrothorax. So instead, we're just going to treat with diuretics and sodium restriction. Another thing I wanted to talk about is DIC versus cirrhosis. So this is a common thing that we sometimes have to try and differentiate because both of them are going to cause increased INR. They're going to cause coagulopathy. But how can you tell if somebody's in DIC or if they're just having, these coagulopathies because of their cirrhosis? So DIC, of course, remember, we're going to be looking for schistocytes on their blood smear, but they also have decreased factor VIII. So this is one of the things that you can check to differentiate DIC versus cirrhosis. With cirrhosis, they will have normal factor VIII. And this is because this is created, it's a factor that's produced in the endothelium. And so in DIC, it's just consuming all of the factors without regard to where it came from. Whereas in cirrhosis, it's mainly just the factors that are produced in the liver that are going to be low, but the factor VIII that's produced in the endothelium is actually going to be normal still, and it's not being consumed or anything by a process like DIC. All right, and that is my overview of cirrhosis. I hope this video was helpful for you guys. Remember the vibes mnemonic for the most common complications that might occur with cirrhosis, and then know some of the other complications like hepatorenal syndrome, hepatopulmonary syndrome, and portopulmonary hypertension. I hope this was a fairly comprehensive review of cirrhosis for you, and so you can feel much more confident managing it in the future. Thanks again for watching. I'll see you in the next video, and peace.